Welcome back to Healthwise, and I'm Reggie Tatum, and with us is Dr. John Kemp, a renowned gynecologist in Opelousas. Dr. Kemp, you know, one of the things we talk about gynecology, but I think one of the things that's really important is cancer screening, you know, as far as in what you do, that aspect.
Right.
Tell us a little bit about that. What should the ladies get? You know, because I know there's mammograms and there's all other kind of different things to do. But what do you suggest they do?
Well, on the first topic of breast cancer screening, breast cancer is a terrifying disease to a lot of women, and you know, most women believe that what happens is you're diagnosed with breast cancer, they cut your breast off, they give you radiation treatments till you glow in the dark. They give you chemotherapy that makes you sick as a dog, and then you're going to die anyway. And for people who won't do their mammogram because they're afraid that's when it's going to happen, it does become a self-fulfilling prophecy. We recommend that you start doing mammograms at 40 and do them annually, starting from 40. Now, women with family history or other reasons may start doing screening tests earlier, but 40. Unfortunately, the government, in one of its plans to reduce the cost of health care, is going to go to the British system where they start doing mammograms at 50 and do them every other year. The unfortunate part of that is that the death rate from breast cancer in Great Britain is 50% higher than it is here with a very similar population.
Wow.
And yeah, that would account for about 20,000 women a year. So as long as we can, at least, we should start doing them at 40 and do them annually. The age group that really I think is the most critical for screening is the younger woman. If you can find an early breast cancer in a 42-year-old, she'll have the other half of her life. She'll get the other 42 years of her life. It's that critical, and it's that big a deal. So start the screening on time and do them often. Do self-examinations. I usually tell my patients to do their mammograms about 6 months opposite their annual visit in my office. The reason for that is they're backup exams. You get a physician exam every year. You get a mammogram every year, and they're offset by 6 months instead of doing your 2 backup exams at the same time like a lot of people do. There are several different screening tests with mammography. MRI is beginning to become a more important modality, but it's still new, and there's a lot of people who just don't have that much experience, maybe 2 or 3 years of experience in reading mammography. One of the questions I'm frequently asked, why do I have to do an ultrasound? You know, mammography, ultrasound, what's the difference? Ultrasound is good at distinguishing between solid and cystic or fluid-filled tissue, whereas the mammogram is better at distinguishing subtle differences in the solid tissue. So it's better as a screening test, but occasionally what happens...
It misses.
Yeah, you'll see something show up on the mammogram, and you're not sure whether it's solid or fluid-filled, because that's a huge distinction. If it's fluid-filled, it's a cyst, and it's automatically benign. It's no big deal. If it's solid, then you need to go on to some sort of tissue sampling techniques. Now, this raises another question, because many times these things are too small to feel. So how do you biopsy something you can't feel? You just whack out a chunk of tissue and hope you got it? That's unfortunately how it used to be. There have been several developments. One is the needle localization. Under anesthesia in the X-ray department, they'll actually put a little wire that's shaped like a letter J into the area in question on the mammogram. Then they'll take you up to surgery, cut out the tissue around the tip of the wire, and then they actually do a mammogram on a sample to make sure that what they got is what they saw on the other film. And then if it is, then they'll go ahead and process it and read it from there. A more recent development, and one that's now available here in Opelousas, is something called stereotactic biopsy. In this procedure, they actually can advance 2 needles to meet at the center point, and then they're perfectly able to make sure that the biopsy that you take represents the abnormality that you see on the imaging study. Because you know, if you biopsy a normal piece of tissue next to a tumor, you haven't done anybody any favors.
Right. Yeah, exactly.
So you got to be sure you got it. They often now will also place metal clips there so that in the future, when you have another mammogram, they'll know, okay, yeah, we know this area, we studied this before. But I think breast cancer should not scare women the way that it does. If if you had to choose between cancers, you know, they said, well, you're going to have cancer, we'll let you pick it. Your first choice obviously would be thyroid, but your second choice would really be breast, because survival rates with stage 0 disease, the pre-invasive breast cancer, 95 to 99%, and stage 1 it's 90 to 95%. Wow. And we're talking cure rates, not just get better for a few years and then fixed, done. You know, and it's often hard for the women to realize that they did actually dodge that bullet.
And you're right. I think they don't realize that. Now, you were saying that stereotactic biopsy, that's the new one. That's the one.
That's the newer one. It sounds a little grotesque, and I probably got to just explain a little bit how it is, because if anybody out there winds up doing it, they'll at least not be surprised. You lay prone, face down, on a table, and your breast actually goes through an opening in the table, and then using fluoroscopy, and they will advance the 2 needles. This is all done with anesthesia too, by the way. Although apparently the suction apparatus that they use to actually sample the tissue does make a bit of a noise, and people are sometimes startled by the loud noise. But I haven't had anybody yet tell me that it was just the worst thing that she ever did. So and besides, if it saves your life, there you go.
It's worth it. Yeah. It's worth it by a long shot. Yeah. So that's breast cancer. Well, you know, I guess we're going to next talk about you being a gynecologist. We want to talk about the cervix, but we're going to wait after we have this message from our sponsors. We'll hit that topic and we'll talk about that and see what can be done to prevent not breast cancer, but cervical cancer.
Yeah.